Hello and welcome to our meeting this evening on managing survivorship. I am Thomas Farrington, the president and founder of the Prostate Health Education Network. It's great to have you with us this evening. We welcome those of you who are here at the Dana-Farber Cancer Institute in Boston, and we welcome those who have joined us online. We have a program that we're excited about this evening. We hope and think that you will find it very informative and productive. I'm going to turn the program over to Dr. Jim Smith. Jim is an ambassador who was with us in North Carolina. He's now in the Virginia area, but he is working with us to really help educate the network members and support them. So we introduced him at our meeting, I think at our last meeting. And so tonight, Jim is going to spend some time talk about early detection screening and PSA.com. Dr. Smith, you on. Thank you.
Very good. Hope I am unmuted and everything. Excellent. I just want to first start off with thanking Finn, Mr. Farrington, Dr. Crawford, and obviously our sponsors, and for everybody that's in this fight against prostate cancer. We're going to talk about this evening through a PowerPoint how to understand the benefits of early detection. Jerry, are you able to pull up the PowerPoint for me? There you go. Can you go to the next slide? All right. Clearly, Finn's mission is to eliminate the prostate cancer racial disparity. Finn has a major emphasis on educating men about the importance of early detection screening. We know that 1 in 6 Black men will be diagnosed with prostate cancer and unfortunately die at a rate 2.4 times greater than men of all other racial and ethnic groups. This is the largest racial disparity for any type of major cancer for men and women. Men diagnosed with early stage prostate cancer have a 10-year survival rate of more than 95%. Let me reemphasize that because in the past, I would always say, if caught early, almost 100% curable. But men diagnosed with late stage prostate cancer have a 10-year survival rate between 35 and 18%. So we have plenty of work to do. Next slide, please. All right, what is the prostate? The male reproductive system is composed of the penis, prostate, and testicles. The prostate is found below the bladder and in front of the rectum, and it produces liquid that makes up part of the semen. Next slide, please. All right, thank you. How big is the prostate? It is about the size of a walnut, and it surrounds a tube or the urethra that empties the urine from the bladder. As you can see, the different size, the lemon being the bladder, the walnut being the prostate. Next slide. All right. So what is prostate cancer? Prostate cancer is the leading cause of cancer in African American men and second to skin cancer in Caucasian men. The most common form of cancer in the prostate is adenocarcinoma, which is normally a slow-growing cancer, but we don't see this type of cancer as often in African American men. Next slide. All right. How is prostate cancer detected? Prostate cancer is normally detected with a prostatic-specific antigen test, or the PSA, and a digital rectal exam. Men typically begin early detection of prostate cancer between ages of 40 and 50, depending on their risk for being diagnosed with the disease. And I'm going to talk a little more about that. The PSA and the DRE are used for early detection. Can you take it to the other room, please? I'm so sorry about that. All right. PSA is a protein produced produced by normal as well as cancerous cells of the prostate. The PSA test was approved by the FDA to monitor the prostate cancer growth, but is also used for early detection. A PSA test requires that your blood be drawn and sent to a lab for measurements. The PSA is not just elevated in prostate cancer. It is also found in men with benign, not cancerous problems. An example of which is benign prostatic hyperplasia or enlargement of the prostate. There is no evidence suggesting that BPH leads to prostate cancer. Next slide. Why should Black men be especially interested in early detection screening? Prostate cancer is the leading cause of cancer among Black men. All Black men are at high risk of being diagnosed and dying from prostate cancer. Black men are diagnosed with a rate 73% higher than white men and die at a rate of 100% higher. This is the largest racial disparity of any type of major cancer for men or women. Prostate cancer can be curable if detected early. And again, the prostate cancer 10-year survival rate when detected early is more than 95% compared to just 18 when detected late. Next slide. At what age should Black men begin early detection testing? Black men should talk with their doctors beginning at age 40 to get a baseline test. A baseline digital rectal should also be discussed with your doctor. PSA testing should continue to be a consideration for men with a life expectancy of 10 years or more. And we're going to talk about this when we go back to FIN PSA. These recommendations are based on information from these following organizations: the American Cancer Society, the National Comprehensive Cancer Network, the United States Preventative Services Task Force, and the American Urological Association. Remember, it is extremely important to talk with your doctor about a baseline PSA test and the DRE beginning at the age of 40. However, age, race, history, family history are going to be talked about and are significant, and I'll talk more about that in a minute. So, what are the signs of prostate cancer? A weak or interrupted stop and go flow of urine, a sudden urge to urinate or frequent urination, especially at night, trouble starting the flow of urine, trouble emptying the bladder completely, pain or burning while urinating, pain in the back, hips, or pelvis that doesn't go away. And that one symptom is always, to me, very scary, because that may mean something else of major significance. Shortness of breath, feeling very tired, fast heartbeat, dizziness, or pale skin caused by anemia. Again, please talk to your doctor about any of these above signs as further assessment is going to be needed. Next slide. All right, FIN guidance. All right, FIN guidance for prostate cancer screening. Baseline PSA testing for African Americans and other men of high risk for prostate cancer is suggested beginning at the age of 40. This is helping to predict their future risk. However, this is consistent with NCCN, AUA, ACS, and United States Preventative Services Task Force. However, we add to this that if you have a father, grandfather, uncle, brother with prostate cancer, we have said start around 35. You need to know with that kind of family history, it's extremely important to start early, because again, early detection brings about the best clinical outcome. PSA testing should not be considered on its own, but part of other tests, such as the MRI and the genetic test. In terms of the MRI, people would say, why an MRI? Well, an MRI, if you can imagine a Legos, and you're stacking your Legos up into a, say, a 6-inch, 12-inch tower. That MRI is making slices of that prostate, giving the clinician a idea of where it's at. And this could also help aid the urologist when they are doing a biopsy if indicated. So the MRI is extremely important. And again, when we look at the digital rectal exam, we know when we enter your rectum and we're feeling on that side of the prostate, we're not feeling the anterior. So we can only feel that one side. And for African-American men, a significant number of cancers are on the side that we cannot palpate during a digital rectal exam. Prostate cancer diagnosis must be viewed separately from the possible treatment of prostate cancer. Active surveillance is an option, but again, for many of African-American men that I have worked with over the years in North Carolina, and especially Eastern North Carolina, active surveillance is very scary. Again, bottom line, African-American men with a family history of prostate cancer, and Vietnam veterans exposed to such items such as Agent Orange, the burn pits, and the like, are deemed to be at high risk for prostate cancer. Next slide. All right. The bottom line is early detection saves lives. Can we take a few questions, and is that possible at this time? Any questions from the audience?
Go ahead, Steve. Use the microphone. Yes.
Because I have a question that I get commonly.
Yes. Hello.
Go right ahead.
Yeah, Dr. Smith. I have one question. I was diagnosed 10 years ago last October, so I'm a 10-year survivor. And I keep seeing that it says life expectancy is 10 years. What does that mean in my case?
I'm glad you've asked that, because we're going to talk a little bit about that in a minute with FEN PSA. But let me just talk about that and answer your question. You know, we take a look at an individual in terms of where they are medically. All right, I'll use myself. All right, I'm 73. I have hypertension. I'm controlled well with my hypertensive meds. I have hyperlipidemia. My cholesterol, both good and bad, are adequately controlled with medication and watching my diet. I'm not diabetic. I have no other chronic medical conditions other than obesity. And with that being the case, looking at my family history, my father made it to 93, my grandfather to 88. I want 20 more years. And if my grandparents can make it that without the medical advances, because you can imagine the care that where we were in terms of care of patients back in the 60s, 70s is, you know, we're light years ahead of that. I finished medical school in 76. So the bottom line, we use it as an average. You know, when I look at our life expectancy table for myself, it says to me at 73, the average of 73 with my kind of condition, I would live up another 11 years, which is 84. That I'm going to do my very best to continue to be screened so that I don't come to miss a cancer that I could have treated. But so for yourself, if you can continue to maintain your medical well-being, work with your doctor, you know, do your best with your meds, do the best with overall care. We expect you to be, we don't, guys, obviously no guarantees, but to live another 10 years. Now, also just remember, back in the day when I entered medical school, African-American men, the life expectancy was 62, which meant a lot of African-American men never even collected Social Security. So we've come a long way. And again, in your case, sir, please do your best to do your health and wellness and extend that 10 years to whatever the good Lord will give you. I hope I answered it.
Thank you.
Hello, good doctor. I have a question for you as well.
Go right ahead.
And that is prostate cancer preventable?
Preventable?
Yes.
Yes, it is not. I wish we could say cancer was preventable, but what we can do say is this. There are certain things that you can do, such as a low-fat diet, exercise, moderate use of alcohol, no nicotine whatsoever. So there are some health and wellness paths that you can take that will reduce your risk. However, if you have that genetic makeup of that grandfather, that father, that uncle, that brother, genes rule. So early detections through appropriate PSA and digital rectal, as indicated, is really the way to go. So maybe one day we would be able to, from a genetic standpoint, prevent prostate cancer, but not at this point in our medical world.
Doctor, I have a brother. He has prostate cancer. And so I'm fortunate I don't have it, but does it skip?
It's a good question. Good question. All right. In terms of the genetic profile, it does not necessarily mean that if your brother, your dad, or your grandfather, that you're going to have prostate cancer. What it means is you have a high risk for developing prostate cancer, but there's no such guarantees. But again, we are Finn, we are about preaching, be safe, early detection, that PSA test, and the digital record as indicated by your doctor are the way to go.
Also, doctor, is there an age limit on prostate cancer? Is somebody like I'm almost 90? I was wondering if there's an age limit also.
No age limit, no age limit. I mean, you know, we've talked about this, and men that have died from some other illness, that on autopsy that they've had a prostate cancer that was not clinically known. No, it just, that's one of those mysteries of life. But the bottom line, though, is this. I think about a patient that I had, was 80 years old. He had been tested every year. At 81, he talked with his doctor's nurse. Between the two of them, they decided not to come in to do the PSA, not to do the digital rectal. He came back the following year, asked to be screened, and he was diagnosed with stage 4 prostate cancer. So it's something that I would say without any hesitation, you have to make a decision with your primary care doctor. Again, my personal decision, I plan to be screened until I transition. It is, there's nothing wrong with a blood test, and there's nothing wrong with the PSA. I'm in a digital rectal. The ladies that support us go through pelvics. The mammogram tries to turn their breast into a pancake. I can tolerate a digital rectal exam, and I certainly can tolerate the PSA blood test. And so I just say, sir, at 90, I'm glad you're with us. I want you to hit to be a 100, and please continue on your current path.
We're gonna hold any other questions. I know Dr. Smith may have a couple more slides, and then we're gonna go in.
Yes, we sure do. Well, let's go to Fen PSA then. All right, Jerry, are you able to? Can you scroll down so I can see the? Yes, very good, very good. It's perfect, perfect, perfect. All right, allow me to introduce Fenn's introducing Dr. PSA. Again, prostate cancer, early detection screening aims to reduce deaths from prostate cancer by detecting cancer that may be life-threatening at an early stage where it may be treated and managed effectively. So we talked about what is prostate and prostate cancer. Okay? No one ever asked me, why do we have a prostate? And we use that. And if someone would like, I could talk about that. But it is an effective organ that helps bring about the survival of the sperm. We've talked about the early detection in terms of screening, how important it is for African American men. And we've talked about what age you should begin screening at that 35 if you have that family history, dad, grandparent, brother, uncle. But what we need, and which is important about what Dr. PSA, is what happens after the baseline PSA test. Can you click on that for me, Jerry? On what happens after the baseline PSA test. There you go. All right. Okay. Based on the baseline PSA number, your doctor at that point may perform the digital rectal exam. Now, let me just talk briefly about the digital rectal. For the longest, before I got into understanding all of this about prostate cancer, my primary care doctor would give me my annual physical, do the digital rectal, send me down the hallway to have my blood drawn for my PSA. And then I learned later that, doing the appropriate DRE, digital rectal exam, would elevate my level of PSA in my blood. So he and I had this little talk. And so after that, I would get my PSA done before the physical. That way I did not have an artificially elevated PSA test. But that PSA test is so important because we watch velocity change. I mean, the rate of change, if mine was 2.0, next year I would expect it to be no more than 2.1. But if next year I'm at 3.2, that rate of change is so high that my primary care doc is going to refer me to a urologist for further tests because of that. You should track that PSA number on a regular basis, compare it to others that you've had in the past, so that if you see that change, that velocity, you know to reach out to your doc for appropriate follow-up. You should get this PSA test each and every year, and sometimes more frequent depending on the situation. So as you see, know your numbers. The organization I work with in North Carolina, we would give out a 5-year card that men would keep in their wallet, so they could have on that card the date of their annual physical, that they had their physical, their DRE, their PSA number, their blood sugar number, and their blood pressure number. That way they can track these important numbers over a 5-year period. All right, can you go to back to the previous screen?
Dr. Smith,
Go right ahead.
I'm going to, this information is great, and I'm going to say to our network members, the key thing that we want to do tonight is want to make sure that you are familiar with finpsa.com, and so that when you're talking with people and you're out with the materials that we have, that you know what this tool is, how it works, etc. Dr. Smith has gone over some materials, and most of you all are already survivors, so you know everything about early detection and PSA screening. We could spend some more time, and I hate to cut you off, Dr. Smith, but we do have to get into our next.
No problem. Well, let me just say this last word.
Okay.
Clearly, early detection works. And I really support this program. Dr. Crawford is going to take you now into the nitty-gritty about treatment. And so I pass the baton to Mr. Farrington and Dr. Crawford.
Thank you. Thank you, Dr. Smith. Thank you. Great job.
All-
Great job. Now, I'm going to introduce Dr. Crawford, and I think most of you may know him. He's our Director of Clinical Trials and Patient Education. Another tool that we have is FinPath. That's our tool for treatment options to provide information about your treatment options based upon where you are on your prostate cancer journey. So with that, I'd like to bring forth Dr. Crawford.
Good evening, everyone. Again, thank you for coming. We heard a lot about what Fin PSA, and remember we use keep it simple. Fin PSA, Fin, if you can remember the Fin aspect of it, then you can understand a lot of the tools that we have available. And it's important that the first stage is to address the disparity that exists within Black men as relates to prostate cancer. But the tools that you're seeing allow all men to use these tools along their prostate cancer journey. So our next tool, FinPath, it focuses on the treatment pathways that exist for patients. And if I tell you a little bit about FinPath, instead of patients having to look at Dr. Google, go on Google to try to figure out what treatment options are available. If you recall, majority of people here were diagnosed with prostate cancer. There was a delay between when you were diagnosed with prostate cancer and then what type of treatments were available. So you went home and you either were depressed or you got on the internet and you started looking for the pathways. So recognizing that that was a problem, what we did was create a tool, FinPath. And I'm going to take you through it. First, let me scroll down. So first, if you think about being diagnosed with prostate cancer, there are those people who were initially diagnosed first time. And then those groups who are folks who are then have recurrent disease. So there's just two general categories. Now, I won't go into a lot of detail, but the important thing is, once you go to FinPath, if you're recently diagnosed, you're going to go to the initial cancer diagnosis panel. You're going to click on treatments, and then we'll help you guide you through each one of the different categories of your diagnosis. So if you're very low risk or you're high risk or intermediate risk, each one of these segments will take you to, and say, for example, to a treatment option. But even before you do that, remember, you have to understand what your risk levels are. That's why it's going to be very important for when you sit down with your doctor, you need to walk away with some basic information. You need to understand what your PSA is. You need to understand what your biopsy results are, your Gleason score, and your cancer stage. All these facts are very important. Now, we also, on our tool, FinPath, we have small, short videos that help you guide you through these particular sections. So let's go back. So we know that if you're initially diagnosed, there's a section here in FinPath. Now, after you receive treatment, the disease can come back. Now, it can come back after surgery. It can come back after radiation. And you can have very advanced forms of hormone-sensitive cancer. But also, and what we're finding is taking a place now, is after you receive treatment for a long period of time, the disease may come back and may be resistant to the conventional treatments or the treatments that are available now. And what does that mean? You've heard the word castration resistant. And castration, just to be clear, we're not talking about cutting away the testicles here. We're just talking about chemical castration, which is the reduction of the effect of testosterone on the cancer. So you get this breakthrough that takes place, and now you have castration resistant. So this is where I want to focus on today. Metastatic castration resistance. Here, you have treatment options that exist. And under this castration resistant category, you can have, there are 3 non-metastatic castration resistant prostate cancer. So NMC, RPC. But we're going to focus on metastatic castration resistant prostate cancer because this is a very exciting area of new treatment options that are available. Because if you go back and you remember, you've heard people say, I have stage 4 disease, and they're about to give up. What we're seeing here is don't give up, because if we were to click on metastatic castration resistant disease, this is kind of puts it like at a level of what people hear about stage 4 disease, and then they're ready to give up. Don't give up. Because when we talk about castration resistant, metastatic castration resistant disease, there are multiple treatment options that are available. And it depends on what group you fall into. You can be a group 1, where you have no treatment. And I want people to understand, this is a very complicated area here, but we simplified it in a video. So after you hear this talk, you can always go back to this site and take a closer look at each one of your groups. So what group do you belong in? Did you have no treatment? Did you have a chemotherapy like docetaxel? Or did you have a hormonal treatment first? Or did you have both? So depending on the group that you fall into will determine what type of treatment options are available. And so here, a person in group 1, this is a patient who has no prior docetaxel, that's a chemotherapy treatment, and no prior treatment with a novel hormone therapy like abiraterone, darolutamide, apalutamide, enzalutamide. So you've heard of these over and over again. Now, if you haven't had any treatment here and you have metastatic castration disease, then with ADT, there's some preferred treatment options. Here, they will start you on ADT plus abiraterone or docetaxel or enzalutamide. And under certain circumstances, you can have CYP-T, radium-223, and so on. But I wanted to circle this here. This year, and this is what's exciting about the treatment options are available. Over the past year, these treatment options have become available, but they're based upon understanding what your genetic makeup is. That's what's important. So we here at Finn, we're constantly asking for you guys to really, we have a clinical trial, what falls in the clinical trial area called Promise Registry. Now, this is a free genetic test. Now, it's not going to go on forever. I mean, they have about 3,600 people already enrolled, and they're going up to 5,000. So if you are here and you're listening and you have prostate cancer, you really need to take a look at Finn Trials. We keep it simple, finntrials.com, and go to the Promise Registry patient summary. And because it's free, you don't have to have insurance, you don't have to any of that. They'll deliver to your door. But back to what we're talking about here. Why do I bring this up? Because you need to understand what your genetic makeup is. If you're a Black man, or if you're high risk, there are these treatment options that you need to have. You need to have your genetic information known before you can take advantage of these treatment options. It's olaparib, and so look at what they say here. Olaparib, abiraterone for BCR. So everybody's heard of BCR. That's breast cancer gene. And a lot of men did not recognize that the breast cancer gene plays a role in the development of prostate cancer. and that there's a therapy that can be used if you have that gene, either something that you've been inherited from your parents, or if they biopsy or take a look at the genetic makeup of that cancer and they find that gene, that mutation. Because here we're talking about mutations in these genes. Niraparib, abiraterone with the BRCA mutation. Talazoparib and enzalutamide, which HRR. So just remember, it's called HER, but it's homologous recombination repair. Now, all of these genes play a role in the repair of damaged DNA. So let's be clear. If you have a cancer that has damaged DNA because of these genes, and you take a treatment that interferes with the repair of that gene, then the cancer has a tendency to slowly stop growing, or even it kills the cancer. So that's why this genetic information is so important. So now let's go a step further and you'll see it again. Now, group 2, a patient has prior docetaxel treatment. So they have prior chemotherapy, right? But no hormone treatment like the abiraterone, darolutamide, apalutamide, enzalutamide, none of those. But look at what we see again. Plus ADT. Then there's preferred treatments like abiraterone, carboxytaxel, enzalutamide. But look at what we look here. Useful in certain circumstances. And those certain circumstances are if you have the genetic mutations, either inherited, something that's passed on from your family members, or it's in your cancer. Again, yes, we'll focus on, again, talazoparib and enzalutamide for HER mutations, right? HRR mutations. Olaparib, which is abiraterone for BRCA mutations, breast cancer mutations, and niraparib and abiraterone for breast cancer mutations. Now, there are other, we've seen those before. If you've been on this site before, you've seen some of the other recommended treatments, but I want to flag this. Again, these are treatment options that are called PARP inhibitors. They interfere with the repair protein for DNA damage. So again, we move to treatment option 3. Again, in this case, the patient has prior treatment with novel hormone therapies, right? The abiraterone, darolutamide, apalutamide, enzalutamide, but no prior treatment with docetaxel. Again, ADT with their preferred treatment. In this case, the preferred treatment here would be docetaxel, but then useful under certain circumstances. And the circumstance here is, do you have the genetic mutation? And what do you see again? These PARP inhibitors, right? And PARP is a protein that plays a role in the repair of damaged DNA. If you inhibit that, then the cancer cells may slow up or even die. So again, rucaparib in this case, plus a breast cancer, BRCA mutation, and niraparib and abiraterone plus a breast cancer mutation. And then the last group I wanted to focus on, this is very important, is patients who've had prior treatment with docetaxel, that's your chemotherapy agent, and then prior treatment with novel hormone therapies. And we've gone over those novel hormone therapies. Abiraterone, darolutamide, apalutamide, enzalutamide. Again, there is preferred treatment options that you'll take with ADT, but they're useful under circumstances. Now, in the past, we talked about the radioligand therapies, the lutetium. And this is where you have an item, the ability of the therapy to hunt down the cancer cell like a guided missile and deliver a radioactive payload specifically to the cancer, and it kills it. Now, but again, you start to see PARP inhibitors, right? This rucaparib, because you have a gene mutation. And then also, we look at this under recommended, other recommended regimens or treatment options. abiraterone, enzalutamide. So what we wanted to say here today is there's this new area of advanced prostate cancer treatment where you have metastatic, so the cancer has moved outside the prostate and it's in other tissues like bone or even some of your soft tissues or in your lymph. But then it's become resistant to just your normal antigen deprivation, your normal first line of treatment. Now, because of your genetic makeup, you have the ability to select or talk with your doctor about using these new therapies. So I'd stop right there, and if quickly, if there's any questions.
Yes, Doc. You mentioned something about, is testosterone a problem with prostate cancer?
So the question that the gentleman had was, is testosterone a problem with prostate cancer? In the beginning, when we start talking about the first treatment to prostate cancer, was found that if you interfere with testosterone, right, then you could slow or even stop the cancer from growing. And that's why, there are treatments where people would remove the testicles, castrate the person, so they remove the primary source of testosterone. Then we move into an era where now we can have these chemicals that have been shown to suppress the level of testosterone or interfere with the testosterone, the chemical itself, binding to receptors, proteins on the surface of your body, but also on prostate cancer. And that has been shown to do it. So yes, to answer your question, one of the fundamental treatment means of treating prostate cancer has always been to either remove the source of your testosterone or interfere with the ability of testosterone to interact with the cancer.
Is there a safe level of testosterone in the body if you have prostate cancer? When does it get to be too much?
Well, it's a very interesting point that you bring up, and we could take it offline. But what we do know is this, that there are treatments out there right now where they'll suppress the testosterone level, right? And then you'll have a holiday and they'll give you high levels of testosterone. So what they're finding out is if we stop it and then start it up at a high concentration, we can cause damage, DNA damage, or damage to cancer so it dies. So now what they're saying is you can have testosterone, but that's why I said this is maybe a topic for a later discussion. And to go into more detail about the physiology of testosterone. But what we can say right now, they're developing new treatments, there are clinical trials that are looking at either suppressing testosterone levels or the interfering with testosterone function, and then you'll take a break and you'll suppress it a little bit again and take a break, or we'll give you high levels of testosterone and you'll go from, it's like taking a bag of ice, bam, 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 high levels, low levels, and it causes damage to the DNA, which causes the cancer to die or slow the cancer's growth. Question? Yes, sir.
I didn't see it up there, but in my treatment, I got shots of Lupron
Right.
that crashed the hormone
Yes.
levels.
So
And they naturally let that hormone level on itself return to normal.
Yeah,
So I didn't see it up there.
yeah, and so in this case, they kind of looped it, and that was a very important point to bring up. Under that Lupron, that's what we were talking about, ADT. So those drugs, that's that first line of treatment that interfered with testosterone's effect on the cancer. So thank you very much for bringing that up. Yes, sir.
To be clear, again, I'm 10 years in survivor. Genetic testing, should I
Yes.
and everyone should
Yes.
go for genetic testing?
I'm saying yes.
Okay.
Yes.
And clinical
Sure.
trial, is that a difference between clinical trial and genetic testing, or is that a,
There, I mean, so in this case, what I'm talking about here, the Promise Registry, well, again, let me say it again. It's free. It's a saliva test. You don't pay for it. They deliver it to your house and you don't need a doctor's order. So let's just put that out there.
okay.
So everybody listening, everybody in this room, you need to get your free test. Because it's not gonna be forever. Now to go back to your question about that 10 years, what's interesting is they group everybody together. So that 10 years is an average, a mean. But look at what's happening. Because we're making, I mean, over the past 20 years, we've gone from maybe 23 years, maybe gone from maybe just Lupron or a single line of therapy to multiple therapies. And then we know more about it, diet and exercise, all of this. And then the question is, when you were diagnosed, was it localized? Was it metastatic? So don't put yourself in a general category. Each person's experience is different. So you have to manage your disease yourself the best that you possibly can. You control what you can control. And if you're staying healthy, because the treatment options are coming down the pipeline. Those, when we start talking about clinical trials, yes, the genetic testing is more of a registry. It's a program. They're going to collect genetic information to make sure what we know, what people have to recognize, and people, the audience out there is, there's not a lot of information about Black men and even Hispanic men when it comes to prostate cancer. When we talk about the genetics, there's not. The majority of genetic information is based upon people who have European ancestry. So that collects the information to create a registry of information that's going to help people, that's going to help those groups who don't have a lot of genetic information. Now, a clinical trial is, what do we know about clinical trials? One, cutting edge technology. Even if you go to NCCN, that's an important statement. The National Comprehensive Cancer Network. These are the organization that designs the guidelines that clinicians follow. That's important. And what they're saying is NCCN believes that the best management of any patient with cancer is in a clinical trial. Because you're going to get your best care. It's not going to be you by yourself and your doctor. It's going to be a team of people. So what do you know? Cutting edge technology. And then let's be clear. When we start talking about a clinical trial, let's be clear. It's not a placebo. At a minimum, you're going to get the standard of care. And standard of care, you know my analogy, standard of care is like 3 scoops of ice cream, chocolate syrup, and nuts, whipped cream. And the treatment, the clinical trial, is the 3 scoops of ice cream, chocolate syrup, nuts, whipped cream, and then the chair. So at a minimum, you're going to get the standard of care. And you're going to have access to all these different technologies before the FDA has approved it. And to a certain extent, it's free or close to free because it may be covered by your insurance, especially if you're in Medicare. Yes.
Yes, I have a question from Brian Hamilton, and he just wanted you to reinstate where you get the information for genetic testing.
Oh, it's if you go to yeah, and So he was looking for it. Yes, that's right. So Fin trials. So, point is this. Fin PSA links to Fin Path. Fin Path links to Fin trials. So there's a continuity here. So if you then go to patient summaries, so if you look at this, so remember what when we start talking about different categories, these are categories where we each month curate, look at all the new clinical trials and put them in their respective buckets. So depending on your diagnosis, you will find clinical trials there. But the question was, what is this genetic test? You went to Fin trials. If you press on the patient summary, and then you look for the PROMIS registry, and you click on the PROMIS registry. We try to keep everything simple. Now you get a nice simple overview. What is the registry study? What's involved? All this is here. And then if some of you guys off of work late and you just want to listen to somebody, then you can click on one of these and learn.
The PROMIS registry stands for Prostate Cancer Registry of Outcomes in Germline Mutations for Improved Survival and Treatment Effectiveness. The PROMIS registry stands for Prostate Cancer.
So everything is here. You don't have to spend your time searching, dealing with Dr. Google. If you have family members who are concerned about when to screen, that's Fin PSA. If you're just diagnosed, you're sent home and you're waiting for your treatment options, you have a tool. This is not an app. This is a portal that you can access on your phone, on your computer, on your laptop, in your doctor's office, and have your doctor look at that. And when they see these treatment options are treatment options that they are following, they're going to be comfortable with it. They don't have to re-educate you about the right treatment options because you're showing them these reliable treatment options. So you have the ability to really have this shared decision-making when it comes to what treatment options you have, because you have the information that your doctor is going to follow. You're not going to go to them with some out of the way treatment option, grapefruit extract, injections, or whatever is out there. You're going to go with NCCN. Any more questions? Yes, sir.
My question is, if you've been going to the same doctor for, let's say, 15 years since you've had prostate cancer, and it's 001, then there's no need to follow up on those registries, or should we still register anyways?
You should always know your genetic makeup. Why is this important? If you have family, so say for example, if you had a daughter and you found out you had BRCA mutation, do you know that because you have a BRCA mutation and your daughter could have inherited that mutation, she could be high risk for breast cancer? Now, we already know that your son, if you had a son, would be at high risk, but what about your brother? What about if you had a sister who had a BRCA, you had a BRCA mutation? You need to tell her or him that they need to be careful and they need to they're at high risk for disease. So having the opportunity to get something for free, to know about it. Now, the next thing is, okay, your PSA is flat, it's low. But what happens if it came back? Wouldn't you want to be in a position to take advantage of these new novel therapies that are more personalized, targeted? They hunt down the cancer and kill the cells with minimum side effects to the other tissue. Or do you want to be in the 20th century, horse and buggy medicine versus personalized medicine in the 21st century?
Thank you.
Any more questions?
I was kind of piggyback, but I believe you answered the question. Even though we're in a survivorship.
If you're in a hiatus?
And we're in a hiatus, it's important to have that
bullet in the barrel, but things happen somewhere down the line. Our information is already in the registry. And on top of that, we can help some family members along the way by knowing what, what our genetic makeup is.
Yeah, because think about it. If you, in this case, let's get it straight, it's free, right? Comes to your house, you don't have to pay insurance on it. The problem is, it's a saliva test, but any test is gonna take time. So what happens if you get diagnosed with prostate cancer? It's increasing. Oh, I'm gonna rush and get a genetic test. I gotta wait 6 weeks. So I'm gonna wait 6 weeks before I start treatment. Oh, doc, look, I have my genetic information. Oh, you have your genetic information. I think we can try these drugs, these treatment options. You need to be ready, because when the opportunity exists where you can take advantage of a clinical trial that's personalized and targeted towards genetics, your genetics of your body or mutations in the cancer, you'll have that information. And what's nice about this program is that they keep track of you and send you information about what's, about cancer and genetics and all this stuff. You're not just, you have a test, they're going to be with you. And especially if you have some of these variants that they're interested in, you're not going to be alone.
Sounds good.
Okay, I have an anonymous question. It says, I've been on abiraterone for 10 months, which kept my PSA below 0.05. In the past 3 months, it has been steadily going up. The last test showed 0.2 PSA. My oncologist says we'll continue to monitor. Is there a better advice for me?
So what is your team? So again, I'm not going to go against what your doctor is saying, but what we're saying has your PS, how old are you? And I think that you should have this discussion with your clinician. How old are you? And your PSA.
He says he's 58.
He's 58. Okay. And then what was the differences? Did your PSA double?
Yes, he said for 10 months, it was at 0.05. In the past 3 months, it has been steadily going up. The last test showed 0.2.
So it's double. I think that you probably should go back and have a discussion with your doctor, because you play a role in your treatment options. Now, we have treatment options, and then with FINPATH, because now what we're seeing is a possible recurrence of disease. We don't know what's going on, but it's very important for you to be engaged with your doctor, talk about your concerns, and then use FINPATH as a resource. We can't tell you what to do. We can provide you the resources that allow you to have that discussion with your doctor and continue to have that discussion with your doctor. Yes.
Thank you.
To the genetic testing, why isn't it done anymore? The genetic testing, why isn't it done routinely?
I mean, that's an important question. Right now, it's expensive. And we're starting to identify the importance of genetic testing. And another thing too is, realistically, a lot of the research that's been done was the research that you've seen at a lot of the academic institutions throughout the country. And now what you're discovering is this link between genetics. And now guess what you have? You have treatments that prey on the weakness, the mutations that exist in cancers. So right now it hasn't been important. There wasn't really a lot out there. And then the other thing too is this, you're going to have to, like all of us, we're going to have to push our representatives, our Congress people, to make those type of treatment options available or cheaper. And that's important. But to answer your question, it's now we're starting to see these treatment options. Now we're starting to see that there's a disparity that exists, because if you want to know There's a lot of genetic information that exists for people of European ancestry. 80% of all the genetic information related to cancers, right, are based upon people of European ancestry. 14% people of East Asian ancestry. So Southeast Asian, Black, Hispanic, people of color, there's not a lot of information. And I don't say that to say, oh, those bad Europeans. I'm not saying that. What we're saying is, in this meeting today, you just heard a free test. You can begin to address that disparity of genetics by participating in this program. So more and more voice, more and more meetings like this, the more and more you talk to your doctor, the more and more you advocate for genetic testing to push it, to make it important. But there's another thing too, is there's also the flip side. A lot of people are afraid because once they know the genetic information, will I not get insurance? Or my insurance won't cover. There's a kind of a two-edged sword. But the point is, it is important that we move in that direction because the treatment options that are coming down the pipeline right now are personalized, targeted. And we don't want to be in a horse and buggy where everybody's riding around in a Tesla.
Are people using AI already putting in?
I'm asking about AI, artificial,
See, now you jump from genetic to AI, yes, to answer the
because
question.
that would be,
But the issue is this, it's not AI by itself. The
but what you
clinicians,
put in, right?
it's the clinicians who embrace the use of AI. So it's not AI by itself, it's the doc plus
Right.
AI. But the point is, in breast cancer, they're using it, especially recently this year, the past maybe 12 to 18 months, the pathologists have started to use AI to help them better understand what they're viewing and to give better reports. So again, that's going to be important. So we talked about genetics importance, and we're going to have to police AI too. Our voices are going to have to be heard to make sure the information that the AI, the machine learning systems are using are accurate and not biased.
Thank you, Dr. Crawford. Dr. Crawford covered a lot of very important information. And I want to go back to the beginning of where we started, and that is our role. Our role at FIN, our mission is to eliminate the African-American prostate cancer disparity, the largest disparity for any type of major cancer. Now, how are we doing that? We are putting boots on the ground with programs that we have in the community. We've had education symposiums. We go out to churches and other places and provide information. We do those things. But in my other life, I ran a computer software company. And so I do understand and respect the role of tools. And so we have embraced developing tools that patients and the public can use to better understand their risk for prostate cancer, what they need to do about early detection screening, the treatment options that are available, the clinical trials that are available, and we're working on other tools. These tools are important because, as I said before, we are going to have to be very aggressive. We're going to be innovative in order to carry out our mission. So we are, what you've seen Dr. Smith talk about with FIN-PSA, that's a tool for the public. That's a tool for people at risk for prostate cancer. That's a tool for women who love the men in their life. They want to make sure that they understand what they need to do about early detection screening and coercing those men to do the right thing about prostate cancer detection. We have, you saw Dr. Crawford talk about FinPath. That's a tool that's based upon, we didn't come up with these treatment options ourselves. We didn't sit in our office and say, what should we put here? What should we do there? These treatment options are based upon the guidelines established by the National Comprehensive Cancer Network. That's an organization made up of experts in the prostate cancer arena. And I've had the opportunity to sit on that guideline panel for more than a decade. And I have seen many of these new treatments come into being. When I first arrived on the scene with the NCCN panel, we did not have that many treatment options. We had surgery, radiation, and we had androgen deprivation therapy. That's what ADT is, androgen deprivation therapy. We had those primarily. We had chemotherapy. And so everything that you see on that list of treatment options have pretty much come about in the last decade and a half. It's important, it's very important that Black men, families understand about these treatment options, understand about early detection screening, understand about clinical trials. To catch up, we are going to have to get ahead of the game. And I think we can do that. I really think we can do that. By the way, I think our tools are best in class. When it comes to these tools that you saw tonight, I put our tools up against anybody's tools. And so now it's a matter of getting that information out to the public. And this is where we come in, this is where we talk about our Survivor Network. And again, needing your support to work on the ground to help us get this information out through our church program, through our disparity rally, to make sure that people know about these resources and people use these resources. That is important goal that we have. We're going to spend a lot of time, a lot of focus in these areas in 2024. And so again, I will say as I ended my introductory remark, we need your support. Many of the members of our Survivor Network joined and they said, hey, we want to help you and support you, Finn's efforts at our community level. But this is real. This is real, ladies and gentlemen. This is real. This will not happen without our making it happen. We won't solve this problem. We won't really make progress towards eliminating the disparity if we don't make it happen. And I want to be very clear about that. So again, I'm happy, excited for those who joined us tonight. And my message to you, number one, is thank you. And my second message is join us. We got a lot of work this year. So join us and let's go out, let's win this game. We can win this game. So I'm looking forward to it. We're gonna have a lot of fun and we're gonna make a lot of progress. So with that, if we don't have any other questions here, then for this part of our program, I'm going to say good night and we'll see you next month. Managing Survivorship. We'll have some more messages for you at that time. So those of you who came online, thank you so much for joining us. Those of you who are here in Boston, thank you for coming out tonight. And good night. We'll see you next month.